Welcome back, everyone. So for the last of the anxiolytics that we're going to talk about will be benzodiazepines, or benzos. So these are downers. They are sedatives, just like barbiturates. However, they were created after barbiturates to try to fix that whole low safety margin issue. So in the road to develop benzodiazepines, we first had this drug called meprobamate, or MPB, which was an early non-barbiturate anxiolytic that was developed in the 40s. So it's an anxiolytic that was less strong, had less of a sedative effect than barbiturates. It also had less cognitive side effects. So all in all, it seemed to be better than barbiturates. So by 1957, then MPB accounted for 1/3 of all prescriptions in the USA, so pretty popular. It does act on the GABA A receptor, just like barbiturates. So it's a partial agonist at the GABA site on the GABA A receptor. So unlike benzos and barbiturates, it does not have a specific site that it binds to. It binds to the GABA binding sites. So eventually it was withdrawn due to the abuse potential, and it still had a very narrow safety margin. So even though it wasn't as strong as barbiturates, it still was very addictive, and it still had that narrow safety margin. So we then was able to develop benzodiazepines. So the development of other anxiolytics was really spurred by the commercial success of those MPBs. Which was, some of the first time that you saw a lot of those ads in like magazines and stuff, being like, take this drug, which the US loves to do. So in 1955, then this dude, Leo Sternbach, who was at Hoffman LaRoche, actually began categorizing a collection of 40 derivatives for bioactivity. And this project was shelved because he found a synthesine error. And then it kind of got brought back because they found that chlordiazepoxide was actually found to have sedative, anxiolytic, and anticonvulsant effects. So even though it was set aside, people were like, hey, what is this? So it was brought to market as Librium in the 1950s, and shortly after, it was followed by diazepam, also called Valium. So Valium came on the scene in 1961. It is famously one of the most successful drugs prior to the introduction of SSRI antidepressants. And it was actually the highest selling medication from 1968 to 1982. So about a 15-year period, it was the #1 selling drug in all of USA. And even now, Valium is something that people know about. It is something that's still prescribed. Now, what effects do benzos have? So they are anxiolytic and anticonvulsant. Why? Because they activate those GABA receptors. And remember that those GABA receptors are inhibitory, so they inhibit that glutamate release. And so that's where we get the anxiolytic and anticonvulsant properties. Now, benzos do have some sedative effects as well. However, they're not as potent of sedatives as barbiturates. So benzos aren't something that's usually used for anesthesia, but it is something that will be used like pre-surgery. So something to help people relax before they get the anesthesia, just to make sure that the anesthesia kind of works as best as it can. So some examples of that would be midazolam, which is a short-acting benzo. So it's used for brief surgical procedures with local anesthetic. And so you do get recovery very quickly. It also shows a recovery in a few hours with anterograde amnesia. So it kind of creates the illusion of anesthesia, where you weren't fully out, like you weren't unconscious like a normal anesthetic, but you don't remember anything during that time that it was there. So it gives that illusion. Now, there is lower incidence of tolerance. We have less severe withdrawal symptoms than barbiturates, and there is a greater safety margin. Now, there was a little bit of a backlash against the commercial success of benzos, and that kind of had to do with the success of Valium. So because Valium was so popular and like its commercial success was ridiculous, that when benzos came on the scene, then people were scared that it was just going to be another drug that was going to be as just as widely commercially advertised as Valium was. So benzos aren't as, advertised as Valium was. And after 1982-ish, then the advertisements for Valium and other anxiolytic sedation drugs actually did decrease. They're not gone completely, but they have decreased. So, what are some benzo uses? So, like barbiturates, the effects of benzos vary with the rate of onset and the duration of the effect in the body. So down here, I just have 3 different benzos, and it's showing, we have duration of effect down here, so from the shortest duration to the longest duration. Okay. So benzos have a more rapid onset and termination of effect with increased lipophilicity. Okay, so that means that Surax here, or oxazepam, would have the highest lipophilicity because it is the most rapid onset and most rapid termination. Now, over here, flurazepam, or Dalmine, would have the lowest lipophilicity of these 3 because it has the longest duration, so it's going to have a longer termination period. It's going to take longer for the onset to occur. Okay? Now, what about the pharmacology of benzos? How do they all relate to each other? So some of the effects of benzos does relate to their slow metabolism and the number of active metabolites. So for example, diazepam or Valium here, its half-life is 1 to 3 days. Okay, but the metabolites from diazepam, some of these are active metabolites, so they can also go on to have some effects, just like diazepam did. So with demethylation, then we get nordiazepam. With oxidation and demethylation, we get oxazepam. And then with just oxidation, then we get temazepam. And you can see that they have different half-lives as well. So diazepam is going to stay in your system for 1 to 3 days. If it's then oxidized, then to diazepam, which is an active metabolite, will then go on and stay in your system for an additional 4 to 18 hours before it is metabolized and then removed from the system. So this prolonged action is beneficial for the anxiolytic and anticonvulsant use. So because we can then depend on diazepam for a while, and then we know we have a little bit of extra time because of the metabolites, then it's going to be, then we get this prolonged action. So this also helps with reducing the withdrawal syndrome because it's going through different metabolites. The drug's going to stay in your system longer, but it's going to slowly leave the system. Instead of a very abrupt ending, it's nice and slow. And so that's what's going to help reduce some of those withdrawal syndromes. Okay, so the benzo metabolism, it does differ a little bit depending on if it's a short-acting benzo or a long-acting benzo. So short-acting benzos enter the brain quickly due to the high lipophilicity, and then they also terminate quickly. And this is because they are actually depot binding in those fatty tissues. So these will tend to have what kind of like a hangover effect because of the slow release from the fatty tissue. So you're going to get a lot of it's going to like leave, but the benzos that are stuck in depot binding are slowly going to leave. So it's going to be that hangover effect where you're not intoxicated anymore and you're not really going through withdrawal, but it's more like a hangover where you're getting a little bit of effects very slowly. Yeah. Okay. Now, long-acting benzos do have a slower onset, again, due to that lower lipophilicity, and they are not going to depot bind as easily. So most long-acting benzos do not depot bind in those fatty tissues. Long-acting benzos will also have multiple active metabolites, where short-acting benzos usually don't have those active metabolites. So again, they're going to leave the system quicker. So these long-acting benzos, they're going to stay in your system longer. They're not going to depot bind, so they're just going to stay active the whole time. They have long half-lives, and then they have those active metabolites, which will also have like medium, intermittent half-lives. And then it will reduce those withdrawal effects due to the slow decline in the systematic level. So instead of just an abrupt, we have nice and slow. So on our graph over here, we've got the hours after the dose on the x-axis and then percent of initial plasma concentration, so how much is in your body. And we've got an example of diazepam and lorazepam. So here, then we have diazepam in the, I think that's a black line. And so diazepam is more, like a short to intermediate benzo. It has higher lipophilicity than lorazepam. So lorazepam's in the red, and this is an intermediate to fast-acting benzo, okay? So neither one's like super short or super long. They're both kind of in the middle, but diazepam is more like a short and lorazepam's more like a long-acting. Okay, so here we can see the effects. So diazepam, it acts quicker, but it leaves the system much quicker than lorazepam. So that's what we're seeing here with that, the metabolites and then just how quickly it leaves, all of that. But both the short and long-acting benzos are eliminated using liver metabolisms, okay? So very low rates of excretion from an unmodified benzo. Almost every excreted benzo is metabolized down beforehand, okay? So diazepam is absorbed more readily into fatty tissues because of that higher lipophilicity. And diazepam has a slower metabolism, but lorazepam persists due to the decreased depot binding. So that means that subsequently, lorazepam is preferred for the treatment of anxiety However, it does still have high potential for abuse. So again, why we don't prescribe benzos first usually is because while they're better than barbiturates, they do still have a high potential for abuse. Okay?